Good evening, everyone, and welcome to my Advances and our webinar tonight. And welcome our special guest, Dr. Emma Adsuar, is right here with us. Thank you so much for joining us once again. This is your third IVF webinar, I believe, with us. So I'm glad that you again have answered and, of course, agreed to present this particular topic with us tonight. And how are you feeling, Dr. Emma? It's been great. It's great to have you here, indeed.
Thank you. It's a pleasure for you to invite me again. And I feel tired. As we were
Right.
discussing, I live now
Yes.
in Dubai, so it's like 4 hours of difference.
Yes.
But I hope that I can manage perfectly and you can understand me.
Yes, no doubt here. So thank you so much, even more that you are spending this very late evening with us. And of course, I mean, that definitely it's going to be interesting. As you know, we will talk about advanced maternal age, and Dr. Atswar has prepared a presentation. She will explain everything, of course, as always, and then it will be time for your questions. So as always, don't forget you can type those in the chat section, and then Dr. Atswar will be happy to help you out. So don't hesitate. I always repeat that because this is your chance to get some advice. This is your chance to find out a bit more on your case, perhaps as well. So don't hesitate. It's all anonymous. So yeah, I can only encourage you to type the questions in. And I'm your host, Caroline, as always. And now I believe we can start with our presentation tonight. Dr. Emma, ready?
Sure, sure.
Excellent. Thank you so much indeed.
Okay, so let's go. Okay, so for those who don't know me, I'm going to explain the way I do the webinars is like basically addressing to patients. So I will use like a common language, so for you to understand properly what I'm going to explain, right? I'm going to switch off the camera. So, okay, so the topic for tonight is the advanced maternal age and fertility outcomes, right? And this is like a really frequent topic, as everyone knows that age of the maternity is increasing worldwide. Okay, as you will see, advanced maternal age. Okay, historically it has been defined as more than 35 years old, but nowadays, in the past years has changed, and we can define AMA. Okay, I'm going to say AMA, so it's because otherwise it's really long sentence to say. So AMA is defined as more than 38 years old. This is what the currently definition, right? Extreme AMA, it means more than 48 years old, okay? Most of you will be thinking like, how come that a woman of 48 years can be a mother? Yeah, because we have the technique that is called egg donation, but we will discuss that later, right? Okay, it's really difficult to define a specific threshold as the effects of age in the eggs quality and egg quantity, okay, is defined as a continuum, not as an, it's continuum. So we don't know exactly from which age, right, the risk, okay, are much higher than the benefits obtained. So, sorry. Oh, okay, I got something here. Sorry. Okay, now. Yeah. So, before, long time, 1980s, okay, the mean age at childbearing was 26.5 in industrialized countries. Nowadays, like 5-6 years ago, but I'm sure that we are a little bit higher. We are about 30 years old at the first pregnancy, right? So, as you can see in the second sentence, right? In 1970s, the first delivery was like in the early 20s. Nowadays, the first delivery dropped into the late 20s, okay? Even though in some countries, the early 30s, right? So we have to say that the first delivery in those women who are more than 35 years old represents 9% of all the deliveries, okay, all over the world. So it's increasing. This percentage is increasing, okay. In 1970s, this percentage was like 3%. So if we see like in 50 years, it has make triple, okay, this number, right? Age 45 to 49 years, okay, rose from 0.39, okay, to 179. So this is a really huge step, a huge jump, right? And obviously, this is thanks to the artificial
Dr. Emma, right now the sound is really breaking. So if you can perhaps just refresh, okay? Because we cannot hear you right now. Dr. Emma? Apologies, everyone. Okay, we need to wait. I will double check with Dr. Emma right now. So just stay with us, okay? We don't go anywhere. I'm sure we'll be able to fix this.
Oh, you cannot. Can you hear me?
Yes, now it's all back. Okay, no worries. Go ahead, okay? We
Okay.
just didn't hear you for like 3-4 minutes. So
But can you hear me?
yes, now everything is okay. I can hear you perfectly. So go ahead.
Okay.
Thanks.
So, I mean, should I start or should I continue?
Just continue, okay? You can start with
Okay.
you can go ahead with this slide and
Okay.
start.
Okay.
Thanks.
Perfect. So, I mean, I'm sorry. I apologize for the connection. Okay. So I was explaining how the age affects the fertility, and I'm sure that this is really concern among all the women, right? It's a continuous decline in number and quality of oocytes, right? When we are in the womb of our mothers, okay, we have like 6-7 millions of oocytes. When we are born, that number dropped into 1 to 2 millions. Okay, in the puberty, we only have 300,000 eggs. We will ovulate between like 300, 500. It depends on the treatment. It depends on if we use a contraceptive method or if we are pregnant or not. It depends on the times that we ovulate, okay? And by the menopause, the perimenopause, we only have like 1,000 oocytes. So as you realize, in our fertile life, during our life, okay, we start from 6 million up to 1,000, right? So when this decline, okay, is more pronounced by the age of 30, as you can see in this graph, you will see that this line is a little bit stable, but from 30 years old, it starts declining, okay? The 35 dependent is a little bit more pronounced, and from 38 above, like the dropping is faster, right? Okay. The chances of getting pregnant for a woman below 30 years old who is healthy in every cycle is around 20-25%, right? So that if you sum up in a year, the probabilities of getting pregnant is 84-90% of the cases, right? When you are 40, okay, you have every month less than 5% of opportunity of getting pregnant, okay? That's the reason why, as gynaes, we recommend, if you are looking for a pregnancy, if you are above 35 years old, only waiting for 6 months, not for 1 year, to visit the doctor, right? Okay. When we are a woman who is more than 45 years old, the probability of getting pregnant is almost zero. Okay, I didn't write zero because all of us, we know natural cases, spontaneous cases that got pregnant, but trust me, are the least of all, right? After 16 years of working, I've only met one patient, who was like 46 years old. Okay, the rest were under artificial reproductive therapy, as I was saying at the beginning, right? Okay, this presentations is focused on the woman, right? But I wanted to also to highlight that for you to understand the difference between a woman and a man. Okay, the male fertility starts dropping around 60 when they are like 60 years old. Okay, so for us, we start having like a dropping when we are about 30 years, right here, and men when they are 60. Okay, for that reason, they can have babies in their 50s, 60s, even though in their 70s. Okay, I'm going to make a little pause. I'm going to define what is infertility. Infertility means 1 year after regular intercourse with no protection, okay? Or, as I said before, 6 months if you are more than 35 years old, or if you have any kind of condition that can delay the fertility, for example, cancer, endometriosis, or these kind of conditions, right? 15% of the couples in industrialized countries suffer from this condition, right? The factors are multiple. 30% is more or less, okay? This is not like 100% true, but like 25-30% of female factor isolated, 25-30% male factor. I have to say that nowadays, currently, we are making a male factor, we are seeing the male factor increasing, okay, because of the lifestyle, okay. 30% of the cases are a combination of both of these, female and male, and 10% remain unknown. That doesn't mean they don't have any kind of cause. That means that the tests that we have nowadays are not enough to diagnose what is going on among them, right? The most important factor for infertility is the age of the woman, okay? It's not the same when the woman is 20 than when the woman is 40, with the same condition, right? For example, if the patient has endometriosis, it's not the same. It's not the same quality in the eggs with 20 than 40. So this is really important for you to have this message home that the age of the woman is the most important factor for infertility, is the factor that leads the treatment, right? Okay, which are the complications when a woman above 35, 38 years old gets pregnant, right? Obviously, the increase of miscarriages. As you can see here, okay, there is like 5% of probabilities of having a miscarriage when you are below 30, right? And you have 22%, okay, of probabilities when you are more than 40 years old. Obviously, I'm talking about 40, 41. If we are talking about 43, 44, the risk increase, okay? Which are the causes? Most of the time, these are chromosomical and genetic disorders, right? These are 80% of the causes when you are more than 40 years old. And why? Because of the low quality of the eggs. When eggs, I mean oocytes, right? Because you have to understand that, as I said at the beginning, we are born with a number of eggs. So those eggs are suffering from our lifestyle. X-ray, smoking, exposure to metals, radiation, overweight, and lung, etc. Right? This is a graph where you could see this is like a normal oocyte, okay, when it's divided, okay. So this is completely normal. It spreads like one chromosome to each cell, and this here and here you can see there is a damage, right? So it's not working properly. This is a disruption, and these conditions are more frequent in older women. Okay. Another complication when a woman gets pregnant in old age, okay, is the high blood pressure or preeclampsia, right? Okay, this is associated when you are, if you compare, okay, the probability of having high blood pressure When you are below 30 years old, it's 4%. When you are more than 50 years old, 35%. Okay, I don't know the law in other countries, but for example, in Spain, and it's not a proper law because it's not written, okay? It's like an agreement among the clinics that they shouldn't do any kind of therapy, fertility treatment to women above 52, 54 years old, okay? And one of the reasons is this, because of the complication that can lead to pregnancy, right? Okay, another complication is the gestational diabetes. You have two-fold probabilities of developing diabetes if you compare with a younger population, okay? Another complication is the placental abnormality, that the placenta, instead of being inserted in this place of the uterus, is inserted in the entrance of the cervix, so that will make that the patient will have to do a C-section, most of the time, a premature C-section, a premature delivery, right? Okay, as I was saying just 1 minute ago, there is an increase of C-section, okay, for two reasons. For an increase of comorbidity, that means because the patient has more diseases due to the pregnancy, as diabetes, high blood pressure, increase of weight, fetal growth retardation, right? Or because the patient thinks that she is like 41, 42, 44 years old, and she doesn't want to go because she's scared. So she doesn't want to go to under a vaginal delivery, and she prefers like the security in quotes, because it's not it's not safer than a vaginal delivery. But the patient is thinking that maybe the C-section is safer for the baby rather than the vaginal delivery, right? So this is one of the reasons that the C-section is higher in older women rather than younger, right? Then another important complication is the psychological impact, okay? It increases the rates of depression and stress. Okay. This presentation is not only to make you be afraid of becoming a mother, okay, if you are in those ages, okay. This is only for you to be realistic, to give you, I want you to give you information and to be well prepared, okay. So is there anything that could be done, okay, to try to minimize these complications, right, to improve the fertility outcome? Yeah, okay, we can improve our lifestyle, okay. This has a really high impact, okay, in the fertility outcome. So one of the things we can work on is in the dietary quality. Why? It's really, as you can see here you can see the Harvard plate, right? So I'm sorry, I know that it's really small, but if you can Google, you could see the exact portions in a normal diet, in the best diet that you can take. And if you see, the half of the plate should be, okay, left for vegetables, fruit, right? One quota for animal protein, right? And another quota for carbohydrates and fat, okay? Why this is really, really important? Because we need fat in order to build hormones, but we need also to have balanced diet in order to work properly, right? Okay. It has been proved also that the chronic administration of oral antioxidant, and that is vitamin C and vitamin E, right, in some studies, okay, improves the quality, the aging of the eggs. I mean, the quality of the oocyte, the quality and the quantity, right? The melatonin, it has also been linked into an improvement of the fertility, okay? The melatonin is a hormone that controls the cycle sleep awakes, right? And this is thought to be helpful because once we are sleeping, we are repairing our DNA, right? Then another factor that is really, really important, and it has a lot of great impact in our fertility is the caloric restriction. I'm not saying to be hungry. I'm not saying that people whose body mass index is below 25, in this case it will be like 22, right, should have any caloric restriction, okay? This is more in people, in women, to be more specific, whose body mass index is above 25, right? The increase of omega-3 fatty acids, it's also proved to improve the fertility outcome by improving the equality. Okay, caffeine, but caffeine, even though it has been linked to a better outcome, okay, it shouldn't be more than 3 because it can increase the stress. It's like if you were stressed, chronically stressed, right? Coenzyme Q10, it has also link. Okay, so we can take this as a supplement. Okay, or we can also take food that is enriched with this coenzyme. And this last thing, I don't know if you have heard, okay, inositol. Inositol is a supplement that is only valid in people who have PCOS, polycystic ovarian syndrome. Okay, so in those patients who have polycystic ovarian syndrome, if we add inositol and folic acid, we will find the response to fertility treatment much better than if you don't add inositol. Okay. What will happen if we are approaching that age and we don't want to be a mother, or we cannot because we don't have a stable partner, or we don't have like the job, we are not professionally stable, we don't have the economically independence. So what to do? Okay, we could cryopreserve our oocytes. Okay, can we do it in any time? Yes, we could, but when is the best moment? Below 30. Okay, that would be the best moment. Okay, if we are realistic, if a woman is not a mother before 30, most of the time is because economically is not stable, because professionally is not stable, and doing the cryopreservation is not simple and is not cheap. Okay, so most of the time we can see the patient that comes to the clinic to do this cryopreservation, okay, are patients from 30 to 34. The most important thing, or we should target those patients to come to the clinic before 35 years old. If you remember the graph I was showing at the beginning of the presentation, right, the drop of the fertility, it was starting at 30 years old, right? But the curve, it was much more pronounced when we reach 35 years old. So if we could freeze our eggs before 35 years old, we will gain a lot, right? When to think about that? As I said, social delay in childbearing, because we are not stable socially, emotionally, economically, right? When we are diagnosed as low ovarian reserve, for example, we have endometriosis, or we have a condition that affects like an autoimmune disease that can affect the ovarian reserve, right? And we are not prepared, we cannot, for different reasons, we cannot have a baby in that moment, right? So we could freeze our eggs too. You will be, I'm sure that you will be thinking, okay, she's talking about a low ovarian reserve, but what is the definition of low ovarian reserve? Okay, when we, between, this is an ovary, right? Okay, as you see, these white spots are the eggs, right? When we see less than 10 white spots, 10 eggs, within the both ovaries, this is when we defined low ovarian reserve, okay? I don't know if you have heard, because now it's like really in trend. One blood test that is called that allows us to more or less to give you the prognosis about the low ovarian reserve, that measure the anti-Mullerian hormone. This is a hormone, okay, as I said, that within the ultrasound can predict the quantity and quality of the eggs that we have, right? Okay, if that test, the results is below 1, this is what we consider low ovarian reserve. Okay, I have to highlight that everything is like as I was saying in the first slide. Everything depends on the age of the woman, right? It's not the same having 10 eggs when you are 25 years old than when you are 43 years old. Because when you are 43 years old, 10 eggs is not a bad result, okay? Even though we don't expect 10 eggs when you are 43 years old, okay? So this is really, really important. And as I said, and I'm highlighting, the age is the most important factor for the fertility outcomes, okay? Then we are late to freeze our eggs. We want to become a mother, but we are like 35, 36, 40 years old, and we are trying to get pregnant, but we are not able. What to do? Then most of the time, what we recommend is to be referred by a reproductive doctor, right? To a reproductive center. As I said, not to waste time, right? So these are the techniques that we can offer. It depends, as I was saying, we have to individualize always the case. So it depends on the case. We can go under IVF, is in vitro fertilization, okay, where the technique is described here. So what we do is we give medication, this white spot. We try to collect as many white spots as possible. We collect them, we put them in vitro, we join them with the sperm, we create embryos, and we transfer, right? This is the technique. This is how is done the in vitro fertilization. Okay. Another technique is the IUI. This is intrauterine insemination. And this is much, much simple. We stimulate the ovary, okay, in order to have 1, 2, maximum 3 white spot, 3, eggs. And then we prepare the semen and we put the semen inside the uterine cavity, right? We come to the clinic, or we decide that we want to be a mother and we are 47 years old, we are in our menopause, or we are not in our menopause, but we run out of eggs. What to do then? We can ask for an egg donor or embryo donation, right? You know, the egg donor, the woman that is giving us, is donating her eggs, is going under this treatment, this technique, right? But the embryo donation, most of the time, is the embryo. Okay, I think that, yes, you're hearing me. But the embryo donations are embryos who are left from previous cycles from different persons, right? Okay, you can see here, women and men, okay, is giving, this is the donor for the woman. This is per donation, but this is not, but this presentation, right? This is the embryo donation, genetically different from the couple, right? The gestational surrogacy here, it makes no sense, as we are talking about the egg quality, and we most of the time the gestational surrogacy means that the patient are extracting the eggs and they're putting the eggs in another woman. In this case, right? They're extracting her eggs, creating embryos, and putting them in another woman. It could be, okay, it could be that maybe A woman can be a mother when they are like 47 and that person doesn't have uterus, right? So yes, we could go through gestational surrogacy, but most of the time in those cases, this is not the treatment recommended. Okay, so that was my presentation, and I really hope that you understood and that I clarify all your doubts. And please let me know if I can help you.
We can hear you, of course, very well. Everything is great. So thank you so much for your presentation, for walking us through everything. You have explained everything very, very well and detailed. So thanks a lot. And now it is time for your questions. As you can see, Dr. Emma, there are plenty of questions ready for you. So let's not waste time. Let's go ahead with them right now. Okay?
Yeah.
Perfect. So the first question is, so why is male factor increasing?
Because of the lifestyle, because of the exposure to metals, because of the smoking, because most of the time they are not making exercise. Everything goes to the lifestyle, right? More sedentarism, more smoking, more alcohol, okay, and more exposures to metals and radiation. These are the main factors that are making the male sperm not being as good quality if you compare it as like 30 years ago.
Thank you so much for the very first question, and I'm afraid that's from what we hear. This is something that it's not going to get any better as well, right? So
no, it's not.
exactly.
It's not. Unless we change the way we live, but it's really complicated.
Yes, of course. Thank you so much for bringing this. This is always a big topic. I guess we could have another webinar on this particular topic, indeed. So thanks a lot. Let's have a look. Next question we have: does calorie restriction have an impact on epigenetics?
It hasn't been studied so far, okay? The studies I was talking about, it was about mice, okay? Mouse, okay? So, and you know that mice and human, we have something in common. So more than in epigenetics, it's more to do with the hormones, right? The way that the egg is built. It makes sense what I'm saying?
Thanks so much, of course, definitely. Thank you so much for that. Okay, let me have a look. Okay, there are more questions coming up, and there's another one. Do antioxidants affect AMH? Because you mentioned that the quantity of X can be increased in addition to the quality.
No, the quality. If I said the quantity, I beg your pardon, because no, I meant the quality, not the quantity. Okay, so AMH is a hormone, and I mean, until recently we thought it was really stable during the cycle, intercycle, and intercycle, it means different months of the same patient, right? This is intercycle. Intracycle, it means in the same month of the patient, different days, right? So we thought it was a really stable hormone. It has been proved that it's not, right? So AMH is linked to the quantity and quality of eggs. So the antioxidants, okay, can have an impact in the quality, not quantity. Even though, as I was saying, the AMH level, it can vary a little bit. It's not as stable as we thought at the beginning. So for that reason, I was saying that to calculate the ovarian reserve, we need AMH plus the ultrasound, okay? Like some years ago, they used to do only the measurement of the AMH, and they saw that it's not, it doesn't give you the well prognosis. Okay, I think I answered your question.
Thank you so much indeed for yet another question and your explanation. Okay, next question. If you have a high BMI but are active, fit, and eat well, if this is still a negative?
Yeah. So I would recommend you to go to the nutritionist, because most of the time we have an error or a wrong idea what it means eating well, eating correctly. As I said, for example, a person who is going to the gym every day, right? And eats salad, you will tell me, yes, is eating correctly? No. Okay, because as I said, you need a good proportion of protein, good proportion of carbohydrates, vegetables, and fat. Fat is really important, so we cannot get rid of the diet. So what I would suggest you is going directly to the nutritionist, a nutritionist that is expertise in fertility. Okay. In the same thing with the sports, we don't recommend, and it's not recommended, it's not only me, right? Okay, but it hasn't been recommended to do sports every day. We need to rest. In order to build the muscle, we need to rest. Okay.
Thank you indeed. And Claire has a follow-up. If you can have a look, you have mentioned this. Can you
Yes,
say
that
something about
the caffeine
caffeine?
has been linked to have a good impact about the fertility. We don't know exactly the mechanism, and we don't know exactly the threshold. Okay, it has been said that more than 3 cups of coffee per day, it would damage. Okay, so below 3 cups of coffee, that would be beneficial. But beneficial, when I'm talking about caffeine, when I'm talking about coffee, I'm talking about the grain. Okay, so it's how you say in English, right? The grain, and then you have to not the grain. It's not the grain.
Bean,
The
right?
bean. Sorry, the bean. I'm talking about the bean, and then you have to use the grinder at the same moment, and then you have to take the coffee instantaneously. The problem with the coffee, most of the time, is that, as I said, because it comes most of us, because we are running to every place, running to the job, running to do exercise, running to wherever, right? We are used to take some capsules instead of like using the grinder, right? So those capsules contains metal. So it's like it's really tricky. It's really tricky to do things perfectly well. So I don't pretend that after this presentation you do everything perfect, because we cannot do that, but at least to be more conscious of what we are doing. And if we can make at least like 1 or 2 changes, that will make a difference. So maximum
Excellent.
three cup of coffee.
Okay, maximum, of course. Thanks a lot indeed. Next question. It's a bit of a longer question. There are 2 parts of this. So let me read this all, okay? And then, of course, I will go back to the first one. So I'm 48, endometriosis history since 21 years old, normal BMI, no other health issues. I have embryos from donor eggs with genetic screening done. First transfer in 2018, implantation, then miscarriage at 8 weeks. What are my risks if I transfer 2 embryos in February? What are the main risk factors because of age endometriosis? Since I have good quality embryos, what are the things I need to know and check for before deciding to do another transfer? And my period was regular. Sorry, I will go back.
Yeah,
I will go back
yeah,
because
yes.
this is the
First,
same patient.
I'm
Yeah,
going to answer the
sure.
first part, if you don't mind.
Sure,
Okay,
no
and
problem.
then I will answer the second part. Okay.
Perfect.
It has been proved that people who have endometriosis, even though they have a donation of embryo, they have more probabilities of having a miscarriage of complications. Okay, why? Because most of the time, this is like much to do with inflammatory factors, and there are a high probability that endometriosis is linked to adenomyosis. Adenomyosis is a condition is for you to is the endometriosis within the muscle of the uterus, right? So it's true that in those women they have more risk of even if you change the egg, okay, even if you have like embryo at the best embryo quality, if you compare with a person who doesn't have endometriosis, who have healthy uterus, okay, you have more more risk of complication. That doesn't mean, okay, that doesn't mean you are not going to succeed. Okay, it's not the first time that we see people who with severe endometriosis okay? With egg donation, that succeeded, okay? I know that it's really hard, and after years of trying, and if you transfer one embryo and if you have a miscarriage, I know it's really hard to face the same issue again, but trust me, try again. This is what I would recommend you.
Thank you, of course, for sharing, and thank you, Dr. Emma, for your advice. And this is the second part, right? So if you can have a look, my period was regular until I did the COVID vaccine. I had 2 short cycles, then no period since September 1st. Hormones blood tests are normal, not premenopausal. Anything you can add?
Yeah, I think that you're talking about the Pfizer because it's the vaccine that has been linked to this kind of, has been linked. It hasn't been linked yet because we are still having a lot of studies, so it hasn't been proved. But it's true that most of the patients are complaining of this kind of disadjustment, okay? So your question is if it could be due to the vaccine. It could be, even though it hasn't been proved. If that is the question, this is my answer. If your question is despite the disadjustment of this hormonal thing, can you go under reproductive treatment? Yes.
Understood, of course. Again, thank you so much. And let's have a look. Another question is up. Is there any way to limit risk factors such as high blood pressure when receiving donor egg transfer at advanced maternal age? Thank you so much for the question.
Exercise, lifestyle. This is the most important thing. Exercise and lifestyle. And obviously, when a patient has more risk of developing high blood pressure, as physicians, we give them the like a preventive medication, right? And obviously, when you are pregnant and if you are some age, we consider a high-risk pregnancy, and we will monitor more closely. But physically, what you can do is exercise and healthy diet.
All right. Again, thank you so much for yet another interesting question. There are more questions coming up, so don't hesitate. Go ahead, type those in. Do you recommend depot before embryo transfer or having the contraceptive pill the month before the protocol?
Okay, there are a lot of protocols, and it hasn't been proved that one is better than the other one. Okay, so that's my answer. So both of them are perfect, are equal, even, but obviously we do recommend this kind of the natural cycle. Okay, we do also natural cycle in embryo transfer, but we do in people, in women. Sorry, I'm always saying people, but I mean women, right? Below 40, because those are the women that have more regular cycles, and we won't expect like any kind of irregularity. Okay, but I mean, both of the protocols the 3 protocols are okay. They have the same rate success.
Wonderful. Again, thanks so much. And there are like 2 questions left, so we will be slowly finishing. So again, if you have more questions, you know what to do. Type those in right now. And the question is, how big is a variation of AMH? Is it recommended to measure it a couple of times to bring the month?
Okay. I wouldn't be so stuck in the AMH level as I said, it has to be linked with the ultrasound. This is the most important, the ultrasound. Okay, ultrasound and AMH, both together. Okay, the variation, for example, I had one patient. She was in May. Her AMH it was 3 nanogram milliliters, right? Because I know that in other countries the measurement is picomole. It's a different unit. Okay, so when I say about 1, 2, 3, I'm talking about nanograms milliliters. Okay, so the patient had almost 3 in May. In December, she measured again and it was 0.8. So we were like shocked, right? Because she was going to undergo treatment at the beginning of December. 2 weeks later, she was like 1.8. Okay, so imagine this kind of variation. So for that reason, I said a number, an isolated number, it means nothing unless it's associated with another test. This is really important. And please don't. I wouldn't like to give you the impression that being so stressed by measuring one thing that isolated, it doesn't mean anything. Okay?
Thanks so much indeed for giving that example. That is definitely interesting, and everyone should remember. Yeah, about that. Thanks so much indeed. Okay, 3 questions left. 4, sorry. I think so. What are the biggest sources of metals? Because I noticed you mentioned metals a few times.
Yeah, coffee. This kind of capsules that has. I'm not going to say the brand, okay, but fish. Okay. Rice. Rice contains a lot of arsenic, so and lead. Okay, so we recommend this. I mean, mercurium, arsenicum, and lead are the most frequent metals, right? So it's simple. You can do a blood test. You can check the level of the metals. Not everyone, please, not everyone. I don't want to create drama and stress to anyone. Only those patients who are trying to conceive and they are not able to, right? Or those patients, for example, that have suffered from a headache or from dysmenorrhea, because this kind of things has been linked also to this kind of symptoms, right? So you can do a blood test, and it depends on the level. The GP or the person or the physician, because for example, if this is not my specialty, right? But they can do the chelation of those metals. So they can give you medication in order to get rid of those metals. For example, in some countries, here I live in Dubai, in UAE, so the tap water, is not drinkable. But some of us, sometimes we cook with that water. We shouldn't, because it contains a high dose of metals, high levels of metals. Okay, did I answer your question?
I believe so. So thanks a lot, of course, for that question as well. And
sorry. And the rice, because I was saying about the arsenic,
okay,
I was going to say, and I forgot. In order, for example, to diminish the amount of arsenicum that the rice contains, we should wash it. Okay, a portion of rice, 5 portions of water. Okay, so for example, in Spain, the rice that is grown in Spain, it doesn't contain too much arsenicum. Okay, I cannot say anything about other countries. I can say about and the whole grain rice contains more arsenicum than the white rice.
Wonderful. Thank you for adding that. This is definitely interesting stuff, so you should remember about as well. Okay, next question is up. 44 doing it.
No, before. There was another question.
Yes. It's okay. I will go back because sometimes it's just showing in a different order. Okay, so it's okay.
Okay.
Yeah, so no problem. I will go back to the previous one then. I'm 44, doing another IVF cycle using the FLAIR protocol, using northarisarone 2 times. I was told this wasn't a birth control. I only got 3 eggs last time and non-fertilized. My AMH is 1.2 picomoles. Is there anything I can do? Am I holding on to false hope at my age?
Okay, I'm afraid that I must say, because when I was talking about I was talking about nanogram per milliliters, right? I'm not talking about picomole. Okay, picomole, if I'm not wrong, is you have to divide into 5, right? So that gives a result of really low anti-Mullerian hormones. That between the 8 gives you a small amount of eggs and low quality. So I'm not saying that it's not going to happen, but the probability of being able to get pregnant with your eggs is really low, okay? With this amount of AMH. As I was saying, the probability of a woman of 40 years old that you are struck, that you retrieve 10 eggs, the probability of having a healthy baby, okay, is 25%. We are talking about 40 years old, 10 eggs, 25%, okay? When we are talking about 44 years old, that percentage drops a lot, and we are talking about 10. So in your case, the only solution I could see, if you want to keep on trying with your own eggs, is to collect as much as possible. Let's see what will happen. But I would really recommend you in your case, and I'm sure that the physician recommended you, is to go for an egg donation. Okay, I don't know what Caroline left.
About this, I'm right here, of course. Thanks a lot indeed for yet another interesting question. And now let's go back to this question. So HCG was 24 on 15, DPO 17 days past Ovitrol, 250 trigger tested out, negative test prior to week positive. Was it residual trigger or pregnancy? Keep progesterone support and do another blood test, or cancel all. What would you recommend?
Okay, 24 and then 15, we can consider as negative. This is residual trigger. Okay, if you have told me, for example, it was 24 and then 40. No, sorry. On DPO, 24 on 15 DPO. Sorry. I understood 24 and then 15. Sorry, this is because of the timing. I beg your pardon. Okay. 24, okay, it could be a residual trigger or it could be pregnancy. Okay, it's 17 days is too soon. You did it too soon, right? So what I would do is I would repeat at least in 3-4 days, and let's see the level. Okay, sorry, I was confused when I read the answer, the question.
Of course.
So continue with the progesterone.
Thank you so much, then, of course, definitely. Okay, thank you for the clarification. And yes, sorry, Claire, I did miss your question. That now I see it. Apologies, but here it is.
Yes.
I'm 43 this month. I have AMH 10.3. Other than diet, what else can I do to help chance at IVF?
Okay, I suppose that 10.3, we are talking about picomole, right? We are not talking about
Claire,
nanograms.
if you can clarify for us, okay, just to make sure.
Okay, because if you are talking about nanograms, the AMH is high. That will mean that you have PCOS. Okay, even though if we are talking about picomole, you wouldn't have PCOS, but your anti-Mullerian hormone is really good for your age. Okay, yes, this is what I was saying, that this is really good for your age, right? So, yes, I would try. Why not? Why not? At least, I mean, have you ever tried to get pregnant? Have you ever tried to do any kind of cycle of IVF? Look, the most important thing for you to understand is that we are talking always about percentages, okay? This is not certainty, okay? If we are talking about 5%, that means that for a specific person, that was 100% for her. I mean, she tried and she got pregnant, okay? So maybe for you, you are not in those 5%, you are the 100%. It makes sense what I'm saying? So if you haven't tried, yes, then they will do ICSI. And he can, apart from the mobility, I suppose that he will have oligo, no? I mean, less amount. He can also take Q10. Yes, he can also take Q10, an antioxidant. But for the sperm, in order to be able to see the improvement, he needs at least 3 months. But I repeat, because you will go under IVF therapy, there are a lot of techniques. You know that the sperm is the embryologist, sorry, the embryologist. We have those, great, he's on it. Okay, perfect then. So the embryologist is the one who is choosing the sperm, right? So that issue will be solved. And they use also max, they use different techniques to choose the best sperm. Okay, so I would give a try because your anti-mullerian hormone is high, so most likely you will have a high amount of eggs. So yes, it's true, you are 43, but you have a lot of eggs. So it's not the same being 43 with 3 eggs than 43 with 15 eggs. You have more chances. So I would try.
Okay, thank you so much, Claire, for your additional information and, of course, for your explanation. Let's have a look. And of course, there's a perfect thanks from Claire for you. And the question that we've got here, what is your take on the supplementation of DHEA in patients over 40?
Okay, I'm not familiar with that therapy. Okay, DHA is the hydroepiandrostenedione. Okay, I'm not familiar, so I cannot recommend you. I cannot suggest you anything. Sorry.
Understood, of course. Thank you still for that. And let's have a look. There is one more question, I believe, here. So let's have a look at this. I had urticaria during my first transfer. I was on granulocyte protocol. Is it possible that I am allergic to granulocyte?
Granulocyte protocol, are you talking about intralipid?
Just clarify this for us, okay? No, sorry, no. So similar, something similar. Not sure if you can clarify that.
Are you allergic to eggs, soy?
Yeah, let's wait. Martina,
Because most of the time it's not the therapy itself, but the components. So this is something you need to find out. We need to find out in your case to check exactly the components.
Okay. All right. So could it be
not the treatment itself, but the components that are I have never seen any urticaria, at least in my experience. I have never heard of any urticaria after the implantation because of the implantation. Not that I know of. I'm not saying it's not, okay?
Of course.
But I'm not aware of that.
All right. Of course. Thanks so much still. And thank you from Martine for your right here as well. And let me have a look, okay? Maybe you can advise. This is just like another patient has added the information here. This is previous question. Thank you. Yes, my doctor wants me to do NORAC. Unfortunately, it's a 2-year wait in my country. Anything you could advise in such case?
I mean, I can recommend you to come to Spain to Vistahermosa clinic because we don't have any waiting list. Okay, and I swear you that the way that the donor is chosen is amazing. Okay, the questionnaire, everything. So that would be an option. I don't know where you are from, and don't know if Spain is really far from you, but it could be a go.
And I believe that was our final question. So thank you so much again for your advice. And well, Dr. Emma, as you can see, there are many thanks right here for you from the patients. So thanks a lot. Definitely good presentation. Thanks for all the answers. Those are just the comments from all the patients right here. So everyone, thank you so much for your questions. You never disappoint with very detailed questions, and we definitely want to see more and more of your questions, because that way we know we can help you out, even if a bit. So thanks a lot. And before we finish, Dr. Adsuar, I know it's quite late for you, so thanks a lot.
No, thank you for having me.
Late evening. Before we finish, anything else you would like to add?
No, that, I mean, I wanted to give you like a story, right, before finishing. I'm 41 years old, and I became mother like 3 weeks before turning 40. But I must say that in my case, I had all the information and delayed the maternity because personal reasons. And it can be done. I mean, and I had a really healthy pregnancy. So I'm a healthy person. I had all the information in my hand. And like me, there are a lot of people. It's true is true that we cannot, how you say in English, we are not confide, no, it's not confide, trust, okay, or think that everything is going to happen easily. Is not. And even though technically we are evolved a lot, there are a lot of development, they develop quickly, a lot of machines, and there are a lot of investigations. Biologically, we haven't changed, okay? So we are still working on that. So please take care of your body. Please think about your maternity, even though you are 30 years old and you think that you don't want to become a mother, or you think that it's not going to happen to you. It can happen to you. So as the same, I mean, all of us, we save money for our pension. So try to save your eggs, or try to save the probability, or prevent to save the probability for you to become a mother. Okay, this is my last message.
And thank you so much for adding this. This is definitely very important. We should never lose hope and try sometimes more, right? Thanks a lot indeed. And of course, remember, it has been recorded. So if anyone would like, you will be able to have a look at this tomorrow, of course. It will be available on our website. Apologies. I wanted to show you where you can find this, of course. It's right here. So thanks a lot. You will find this on also on our YouTube channel. So I can only encourage you to subscribe. That way you know when the video is uploaded. And I can only say again, thanks a lot, everyone. Thanks for spending this evening with us. I do believe it has been useful. I see from your comments that it has been useful. So thank you. We will be back. Dr. Adsuar, I'm already looking forward to have some more webinars with you. It's always great to have you here as our guest speaker. And it's been a very, very, it was a brilliant session indeed. So what else can I say? Thanks a lot. And now have a very good evening and good night to you, Dr. Adsuar. Get some rest, definitely. So
yes, thank you
so much. Take care.
Bye.
Bye-bye.